Um, Let me just ask, how many of you, by show of hands, is in direct service to people with disabilities? Okay. So that means most of you are. Let me tell you what I'd like to do with this 40 minutes that we have together. First of all, I want to tell you 3 stories of 3 remarkable practitioners. 2 are remarkable in a good way, and the third is remarkable in a very bad way. Then I want to talk to you a little bit about evidence-based practice, and maybe I don't have to spend as much time on that as I thought I would, because Trina has summarized what I was going to say so very well. Then I'd like to talk to you about a rather esoteric, abstract concept, which is models of disability. And this is the way that we define disability, we determine treatment, we determine plans. We decide in the university curriculum which department studies disability. And so we'll talk about models of disability, although in the breakout session, which is going to be right after this, you will learn everything you ever wanted to know about models. And then last, we're going to talk about collaboration. And do I leave time for questions? Okay, I think we better leave time. Yeah, and make sure that you hear for me. Okay. So, have any of you heard of the APGAR scale? Okay. I thought that APGAR was an acronym, that the A stood for something, the P stood for something, the G, and it's a person's last name. And Virginia APGAR was admitted to the Columbia Medical School residency program in surgery in 1929. She never married. She did very well in her surgical residency. She was exacting about everything that she did. She played the violin beautifully, and she also built, is that what you say? She also built her own violins. Yeah, she was a very remarkable person. She began flying single-engine airplanes at the age of 59. Well, she was one of the few women surgeons in the United States in the early 30s. And her advisor told her that she would never be able to have a surgical practice, that as a woman, no one would trust her to do surgery. So she decided to become an anesthesiologist, and that would keep her in the operating room, and that was what she really loved. So she had over 20,000 patients over her career. But her favorite things to do, her favorite type of anesthesiology was childbirth. And although she never married, never had children of her own, she never delivered a single baby as a physician. But she loved to be in the process of childbirth. Well, what happened was that if babies were small, low weight, in any way malformed, or weren't breathing, the doctor advised the nurses to put the baby to the side to allow the baby to die. And so She was a forceful woman, and so she would take the baby from the nurses and she would do 5 simple things. They're so simple, I shouldn't need notes, right? But I do. She devised the APGAR scale. Very simple. It is from 1 to 10, 10 being excellent, 1 being terrible. The baby got 2 points if he or she were pink, 2 points if he or she were crying vigorously, 2 points for breathing, 2 points for moving all 4 limbs, and 2 points for a heart rate over 100. And so up until the 1950s, 1 in 30 babies died at childhood. The United States had one of the highest infant mortality rates in the Western developed world. We're still not the best. There are still, the Scandinavian countries beat us, Portugal, Japan beat us. But she published in 1953 this APGAR scale. And what it was it replaced clinical judgment. It replaced that this is the way we have always done things. It replaced, I am working alone. I am the physician, and I don't collaborate. I make decisions, and no one questions my decisions. And these were decisions that were literally life and death decisions. And so what she found out, that if she took these measurements at 1 minute post-birth, and again at 5 minutes post-birth, even without any intervention at all, there was a great improvement. And so she started to warm the babies and give the babies oxygen. And she started saving lives of babies. And she is considered, as the PowerPoint shows, the mother of neonatal medicine, the mother of newborn medicine. She also revolutionized childbirth for mothers. I think 1 in 50 mothers in the United States died in childbirth. So probably childbirth was the most dangerous event in most women's lives. She revolutionized this because she could see that there were different types of anesthetics which were better for the baby and also saved the mother's life, like spinals and epidurals. And she pioneered the thought that maybe they should discontinue the use of general anesthetic, that it put the mother's life at risk and it also put the baby's life at risk. So hospitals began to get competitive. They wanted to publish numbers of their low infant mortality rate and of their low maternal rate. And so now, in the last 2 years, the American Academy of Pediatrics has certified 4 different levels of neonatal intensive care units, all the way up to 4 NICUs. And so the story about Virginia APGAR is she was someone like you. She was someone in direct practice who made observations, who kept pretty primitive records, just counting numbers and what worked best. And she began to see patterns. And she did not set out to start neonatal medicine. She started out to save each baby that she could. And she left her profession in a much better place, just as you can leave your profession in a much better place. In 1930, the birth rate of 27,000 mothers, with the 1930 birth rate, 27,000 mothers would have died last year. Now fewer than 500 mothers die in the United States in childbirth. And so hospitals became competitive. Hospitals wanted to compete with each other for low numbers, and the little 10-point simple scale is still in use today. Here's another person, and I'm sure that a lot of you know about her. Who is she? Oh, I guess you know. Well, she's an Arizonan, isn't she? She died in Tucson, I think in 2006. She was born in Switzerland in 1926. She wanted to be a doctor, but her father said no. Her father wanted her to be a secretary in his business. So she left home at age 16, and she became a hospital volunteer in refugee camps after World War II. She was profoundly affected by visiting a concentration camp in Poland. And there, all over the walls, some of them children, had drawn all these beautiful pictures of butterflies. And these were people who knew they were going to their death, and the last thing they did before they died was to paint butterflies. Well, she went to the University of Zurich in 1951. She met an American medical school at the university, student at the university, and his name was Emanuel Ross, and they married, and they came to the United States, and she specialized in psychiatry. So at her hospital, there were weekly symposia where the doctors got together and talked to a patient and learned about the patient. And one day, one of her psychiatrist colleagues was absent and asked her to fill in. And so they brought in a 16-year-old girl who was dying of leukemia. And they started to ask her questions, all these physicians. You can imagine how intimidating that would have been. And they started asking her about leukemia and the progress of the disease. And all of a sudden, the young girl shouted, "Why don't you talk to me about something that's important to me? I want to know why I have to die. I want to know why I have to die at age 16. And this experience really touched Dr. Kubler-Ross, and she decided that she would specialize in people who were dying. Now, you know, in the olden days, people got an acute infection or disease, and they were dead within days. Now that we have antibiotics and all sorts of medical procedures, we call it the mattress death, that most of us are going to lie on a mattress for a long time before we actually die. That there was death, but there was no dying. It took 3 days and you were gone. And it wasn't a very safe environment in the olden days, not a lot of public health procedures or things like that. So she hit a demographic trend. And the demographic trend was this: the growing longevity of Americans coupled with a new process of dying, where you die of a chronic long-term disease, and it might take years. And so she started to interview these patients, and she saw a pattern, and now I can't remember, oh, now I do remember. It's denial, anger, bargaining, depression, and acceptance. And that has become a great, well-known theory of loss. We often use it with people who have acquired a disability or parents who have a child with a congenital disability. Well, in 1969, she wrote a national bestseller, New York Times bestseller. Now, I write books, but I'm never going to be on the New York Times bestseller list. So can you imagine what it was for a professional person to write a book about her experiences and what she had learned and have it hit the bestseller list? Everyone in America was reading it. It was a revolutionary concept at the time. Talking about death was somewhat taboo, certainly discouraged, and she gave a voice to dying people. Nobody wanted to hear from dying people. She did these interviews, and as you can see, it took her about 10 years to publish the book, maybe 15. But she talked to all these people and their families, and she began to notice patterns. And so she devised this theory, and now it is widely used throughout the United States. Also, she is considered the founder of the hospice movement. You know that the hospice movement came in the 1960s or the 1970s. And also, she founded the specialty in counseling of grief counseling for people with divorces, for disabilities, for job loss. And so these were two people who were in direct practice, as you are. These were people that went to work because they needed the paycheck. I'm going to make this assumption, as you need your paycheck. I certainly need mine. And they were people who wanted to serve individuals, as you want to do, and as you do. But they were also people who left their profession in a better place than they found it. They left a legacy. And there were no meta-analyses, no gold standards, platinum standards, no structured linear models, or they just made observations and recorded them. Now, there have been all of those wonderful things, meta-analyses and structural linear models. We've had all of that to validate their research, but they did not do that themselves. People that came along later did. Okay? And so I think I've said this. Both of them respond to demographic changes. Can you imagine losing, what did I say, 27,000 mothers in America in childbirth? And we lose 500. It is no exaggeration to say that Virginia Apgar has saved millions of babies' lives. And yet she didn't get to do what she wanted to do. She wanted to be a surgeon. And they responded to demographic changes. And so evidence-based practice is about integrating individual clinical experience with the best external evidence. And my favorite word in that sentence is individual. It means that I can make a contribution, you can make a contribution. Yes, we get paid, and yes, we serve individuals, but we can be scientists, we can be researchers, and we can leave the field better than we found it. And continual improvement and evidence grading. And you can see that this happened with both Kubler-Ross and with Virginia Apgar. Here's the bad one. So, that's the thing about publishing. Everybody thinks publishing is so great. But publishing is permanent and it's visible. And if you're wrong, it's permanent and it's visible. And he was the first to say that refrigerator mothers caused autism in their children. And that's one of his quotes. And I could spend the whole morning telling you of how he exaggerated his successes. He had the orthogenic school at the University of Chicago, which makes the University of Chicago look terrible. He had no collaborations. He ran the orthogenic school the way he wanted it to. He didn't allow parents easy access to their children. And so he exaggerated his successes. He falsified aspects of his background. He'd been in a concentration camp for 10 months. And then he had influential American friends who got him out of the concentration camp and to America. He said he had degrees in psychology. His degree was in art. Not that there's anything wrong with art, but, he said that he studied under Freud. He never met Freud. He was accused of plagiarizing. And this is an interesting case because I have books by Bruno Bedelheim on my bookshelf. I was trained to worship this man. I was trained, and just not me, but everybody else. And so this is an example of bad science, where no one ever asked for evidence. No one ever asked for data. No one ever asked to look at what he had done. And the sad thing about, he was also called Dr. Brudelheim because that's funny, isn't it? Except if you're one of the children who are being brutalized, he was very cruel to the children, the children whom he had decided had autism, which everybody knows now is a neurocognitive disability. Has nothing to do with parenting. And the sad thing about it is when families are in despair and frantic to find help, they were blamed for causing the problem. Another sad thing about this is he probably, this is my personal opinion, but he probably delayed real research into the causes of autism by at least 30 years, when real research could be going on. And Temple Grandin's mother said, not about Dr. Bedelheim, but, well, he wasn't even Dr. Bedelheim. He didn't have a doctorate degree. But said, I am still waiting for an apology from the doctors who sat across the desk and told me that I was responsible for Temple's problems. So to me, those are fascinating stories, and each responded to a need in time. In the 60s and 70s, they were beginning to distinguish autism from childhood schizophrenia and mental retardation. So that was a demographic change, and he did not respond too well to that. Who is going to do the first one on this PowerPoint? Who is going to formulate the right question? The answer is you. Who knows the most about number 2? The answer is you. Who can define variables the best? The answer is you. It probably might take a researcher to do measuring of the variables. Researchers will replicate, expand, and evaluate. That's certainly what they did in the case of Virginia Apgar's methodology, certainly in the case of Kubler-Ross's, and it will provide a base for day-to-day professional practice. Here's a quote, almost 20 years old. Although there has been a tremendous increase in the size and output of the scientific community, in the number of books, journals, and articles written, much of the empirical research remains flawed by conceptual limitations and methodological errors. The number of investigations that are flawed from inception. So, when you make a mistake, you want to make it really far down the road. Well, these people started out wrong. So they are flawed by they are flawed from inception by prejudicial, common sense assumptions, by theoretical biases, or by methodological error remained high. So prejudicial, common sense assumptions and theoretical biases. These errors are functions in great part not of incompetence in the mechanics of research, but of asking the wrong questions, of incorrect notions of the meaning of disability to those who live with it, and to the lack of understanding. So this makes your role in evidence-based practice and research even more important, that we academics, we researchers, don't get it wrong in the first place. Let me just tell you about models of a disability, models of disability. When I wrote my first book, I went around and I asked really smart people, what is a model of disability? And they said it's a paradigm. I said, what's a paradigm? It's a model. And it was so frustrating. And I just wondered, what's wrong with saying, I don't know? Rather than just putting something out there, answering the question. And so I came up with 4 models of disability. And a model is an abstraction. It does not exist in reality. Models are human-made representations of reality. And so when you see it's made by people, you can see that it will reflect the historical period in which it was created or developed, and it will also reflect values, because people have values. and they're not harmless abstractions. I don't know if any of you were watching the disability history slides before we began this morning, but the Nazis felt like people with disabilities were life unworthy of life. The Nazis felt like they were a drain on the German folk, the German people. The first thing they did before killing them, and this is years down the line, they measured or counted to the penny how much it cost to house and feed someone with a disability in a residential facility. They put a dollar sign on that person. Then they said this person doesn't even add anything to the German folk. This person takes away. And so they killed 200,000 Aryan Germans with disabilities. And they were never called to accountability. At the Nuremberg trials, nobody talked about these first 200,000 people. So I'm just giving you probably the most extreme example I can of human-made representations of reality. For the Nazis, the way they saw disability and the people who experienced them was life unworthy of life. So it's not harmless. It affects the everyday experience of people with disabilities. In Nazi Germany, whether they lived or whether they died. For us, in our society, it's whether they work, whether they can go to school, whether they have civil rights as Americans, whether they're employed to the utmost of their potential. So these are not harmless. And as I said, they are open to change. They reflect the historical period in which they were constructed. Sadly to say, most research is based on the biomedical model of disability. Oh, and I also, in this third edition, put in the religious moral model. And I didn't think when I wrote the first two editions that mattered, that nobody really believes that God or some supreme being gives people disabilities because they've sinned. I didn't think anyone would believe that. So I thought it was too obsolete, but some people said, yeah, there's some people in my extended family who honestly believe that the reason we have a child with spina bifida or so forth. And it also illustrates how hard it is to kill the charity movement. That this comes out of the religious moral model where good people give money to bad people. And we can't get rid of the religious moral model. So I put it in this next edition. So we have the biomedical model, and then we have the environmental model, the functional model, and the sociopolitical model. And only the last three are interactive. Okay? So here's what models do. They define disability. And this gives different it defines variables differently. It identifies causal attribution and responsibility attribution. So in the first two models, the biomedical model, the problem is deviance, pathology, abnormality, and it is entirely the person's problem. That whatever disability the person has, it's his or her problem, and he or she should deal with it. It's your bad luck, you deal with it. And the biomedical model lets society off the hook because it made disability a medical concern. And so we could say as a society, we don't have to do anything for people with disabilities because it's a medical concern and the doctors are taking care of it. The third is determines needs and treatment. So if all of the needs are medical, all of the resources are medical. After the American polio epidemics, which were the largest in the world, both in number and people affected, left many people with disabilities. Not one polio survivor received funding for counseling, for family counseling, received assistive technology other than mechanized wheelchairs. When the vaccine was discovered and widely disseminated, people forgot about polio. They forgot about the hundreds of thousands of Americans who lived with a disability. To this day, they don't know why the polio virus in some people goes into the spinal cord and in other people is excreted out of the body. Most doctors today aren't trained in post-polio. That's because at that time in the United States, the only model of disability was the biomedical model. So determining needs and treatment, you don't need any counseling, you don't need any help with jobs, you don't need any marital counseling. Let's see. And it guides the formulation of laws and policy. Do you ever wonder why the Social Security Act is such, well, I can't think of a better word, a mess? Because it was formulated in 1935. No antibiotics, no assistive technology, no psychotropic drugs. It was founded before medicine made its greatest leap, and it's founded on the biomedical model. Vocational rehabilitation is founded on the functional model, and the function is working. Special ed is on the functional model, and the function is learning. So not only do you have to have a disability, which is totally within the person, but it interacts with functions. So in some areas of your life, with some functions, you don't have a disability, according to the functional model. It determines which academic disciplines study disability. So most American university graduates, I think this is deplorable, graduate without any knowledge of the disability experience, disability history, the wisdom that people with disabilities can teach us, and they graduate magna cum laude and they feel very well educated. And yet the next day, they could have a disability. It's an open minority group. So, of course, I think that every academic discipline should study disability. If you're in law and political science, you need to study disability history and disability law. If you're in history, you should know about the Nazi genocide of people with disabilities. You should know all about what was on those slides. So it shapes the self-identity of people with disabilities. When you hear something long enough and from very prestigious sources, you begin to incorporate that into your self-identity. You begin to think, well, maybe I am that way. Maybe I do deserve to be treated poorly and not get things that other people are just totally given freely without asking. Maybe I am inferior and deviant. It can cause prejudice and discrimination, and it also provides the starting point for research. Now, when I say the biomedical model, I'm not talking about doctors or any other clinicians. These are abstractions. And doctors work as they have been trained. We all take licensing and certifying exams to keep our professions and take continuing ed credits. And so we're kind of educated in the biomedical model. And we treat and give services to people based upon our education. I don't know if I ever told you this, but I was educated to believe that Dr. Beetlheim was right. And I got A's on exam because I said he was right. He did a lot of damage. So I'm not downing doctors or nurses. Well, one of the things that is a topic for this this conference is collaboration. And I think models of disability really fit in well with models of disability or collaboration. So, in the functional model, it is not that the person is deaf. It's that there are no sign language interpreters. In the environmental model, it says that in certain environments, people can do very, very well. The father of Head Start, Bronfenbrenner, was a Russian Jewish immigrant. His father was the medical head of a New York State residential facility for people with profound to severe intellectual disabilities. And some of these people came in and cleaned, and Bronfenbrenner was an only child. And this, as you know, this facility was way out in the country. And so who do you think his playmates were? They were the residents. And so some of these people were paid to cook for the Bronfenbrenner family, they were paid to do the yard work, and they were paid to do house cleaning. And one thing that Bronfenbrenner learned as a little boy, and it has started Head Start, maybe I should make him the fourth story I tell, but he said that when they were in our house working and talking to my parents, they were very smart. When they got back to, we don't call them barracks, the dormitories, when they got back to the dormitories, they became very dumb. And that is, that's the environmental model of disabilities. In some environments, you can have a disability and in others not. And so what we're saying is, can you change the disability? A lot of times, people with disabilities are posed with this question. If you could take a magical pill or a magical surgery and have your disability eliminated, would you? And that is such an insulting question in the first place, but how about thinking that society is the magic pill? Society is the magic surgery, that we can make the environment different, we can make the functions different, and especially with assistive technology today. So, collaboration. What if we each worked on a different model of disability? And the biomedical model certainly has its place. Our criticism of the biomedical model is that it's been in place for thousands of years. It's been the authority of a handful of a few highly educated people, and it sees disability as deviance and pathology. In a perfect world, in the biomedical model, there would be no disabilities. Disability is an aberration. and aberrations typically aren't good. In a perfect world, in the environmental models, the environments would be tailored for people with disabilities. In the functional model, there'd be assistive technology available and support to get them into school and so forth. It reduces standardization. So if we look at 4 models of disability, we have 4 professionals looking at the definition, the treatment, and what the disability means to the person. The sociopolitical model says that disability is a civil rights issue. That once medical stabilization has occurred and secondary conditions are monitored, that the biomedical model looks at the highest quality of physical life. Those are important things to people with disabilities. So we're not saying throw out the biomedical model. We are saying add to it. Ask people who work with people with disabilities. Ask people who have the disabilities, what are the problems? What do you see going on here? And then help me to design a research program. So models of disability are relatively new. They help us to see disability from many different aspects. Is one model better than another? No. We wouldn't want to be without medicine. That's silly. I will say that the sociopolitical model most clearly illustrates or describes the daily life of people with disabilities. They will tell you that they can manage the disability fine. They will tell you that it's not on their mind constantly. But they will tell you that the lack of civil rights, the attitude of others, that's what makes disability harder or more difficult. So should we work on the person? In the biomedical model, we work on the person. But no, the problems are lack of civil rights and societal attitudes. We work on society. That's where the problem is, and that's how we cure the problem. So I'm so pleased to come to Flagstaff and meet with all of you, and it's good to see Trina again. I do think we have 5 minutes for questions. Yes. Okay. Oh. Yes. I think that's an excellent question. I do think that, if you went to business school, have a bachelor's or an MBA, you're never educated in people with disabilities. So, and then you get into big corporations and you get the HR person, the human resources person, who is thrown all the disability law on his or her desk and say, read through this. And then they are frightened to death of lawsuits. And so in some ways it actually hurts people with disabilities. And so I think that will come about more slowly, but I think maybe in the next generation where there has been inclusion from first grade on up, where all the university curricula talk about disability history and so forth. I think that people with disabilities will become to be seen as normal people. You know, not, I don't know what that means, but normal people without with disabilities. So I think it will come, but I think right now we've scared big corporations. Thank you. Okay, I got it. Yes. These are really simple questions. Next. Yes. I think that we all. Oh, okay. Okay. She just told me what you want to hear. So, I mean, we are a team. We go on the road. So I think that we all operate on a model, but we don't know we're operating on a model, and we don't even know there are other models. And I think collaboration is the beginning to have people say, well, I see disability from an environmental model. Or I see disability more from a functional model. And somebody once asked me, well, why don't you squish all the models together and have a biomedical function, environmental, something else, all together? And I say, to me, it makes more sense to look at each model and answer each of those 9 questions. Going back to the simple example of so-and-so has a difficult time getting a job because he is deaf. So-and-so has a difficult time getting a job because there are so few sign language interpreters in the United States. That's the magic pill. Now here's what Trina says you wanted to hear. So really listen, because you're dying to hear this. Are you signing my check? Oh, no. At Utah State University, I wanted an undergraduate class in disability experience. I wanted to define all the sources of prejudice and discrimination. I wanted to show how they have not been given their civil rights, how the Supreme Court weakened the intent of the Americans with Disabilities Act. And I wanted it open to the entire university, and I wanted it open to all majors. And so this was in the late 1990s. And I didn't want it just to be a class that was offered, that some professor has whipped up a nutty, kind of esoteric, narrow kind of a class. I wanted it to be a graduation requirement. So it goes to what is called Education Committee. And at our university, they meet twice a year, and they're made up of scientists and engineers and English professors. And I think there was even a psychology professor, which I'm shocked, shame on that. But so they decide what are the graduation requirements of anyone graduating from Utah State University. So I had 5 rejection letters, and I saved them because they were so, I thought they were idiotic, but who am I to fight with a rocket scientist? But they said that disability is a narrow concern. So then, of course, I wrote back, 20% of the pop, blah, blah, blah. It's the only open minority group, blah, blah, blah. 1 in 16 births has a congenital disability. College-age people are kind of childbearing years. Shouldn't they have some knowledge? Because some of the people in that classroom will have babies with disability. Then the next letter said it's a clinical concern, that this should be in the nursing department or medical school, that disability is only a clinical concern. So then the next letter I wrote back was full of the sociopolitical model, where it said it's a civil rights concern. And so 5 rejection letters, the 6th was an acceptance. And it may not have been a true acceptance. They may have felt like, we got to get rid of her. And I know you can empathize. We got to get rid of her. So after 3 years, and so at Utah State University, we have 5 general sociology, social sciences courses, 5, and you have to take 2 to graduate, and any 2 you want, and society and disability is one of the 5. And so maybe people don't take it because they're interested in disability. Maybe they only take it because they have 2:30 on Tuesdays and Thursdays open, and they're trying to graduate. But I don't teach it. I'm not allowed to teach undergraduate courses because PhDs have to stay in graduate level. But I do supervise it and read the teaching evals. And many, and I'm not kidding, many say every student in this university should take this class. This class changed my life. This class made me realize I had a disability, that I wasn't a freak. This class made me understand my brother better. And what the instructor of this course tells me is that she's always amazed at how many people in the classroom divulge that they have a family member with a disability. So to that Gen Ed committee, it's not a narrow concern. And we have to cap it. We do 100 students a semester, and there are still more, and it caps in the semester. You know how you have early registration? It caps in April for fall semester. So that's my next battle, is to get extra sections opened. Yes?
Thank you very much for presenting today. I'm very much enjoying the model. I want to talk to you. And we happen to be sitting here in Arizona, New Mexico, Utah. If you go back and look at the history, actually the Nazis spent their time over here to study the Native American population's cleanses. And they based many of their theories on what they were doing in the Carolina. And I still think that permeates the environments that we see here and the belief systems that we have here. And I'm very fascinated as to think about the model of people with disabilities living in Arizona and its populations in New Mexico, and what they might be able to reframe, because many of us live in our biomedical models to treat, and we don't realize the environment here is a sensitivity to that. So I think it provides some really interesting pieces as we think about where that history has led us.
Okay, thank you. She's an occupational therapy professor. Oh. Oh, to end? Okay. And I didn't know that the Nazis came and studied native peoples in America. I didn't know that until you told me. Thank you.
I just want to say really quickly that Julie's going to be here all day, okay? I know everybody wants to talk to her. I will make sure that she's available at the networking session as well, so that you can ask more questions. And we're going to have a break so that we can get to our next breakout session. Thank you very much, Julie. Sorry.